Well, welcome back, everybody. It's time for our final session. This one is from Ramona Naicker, who's going to talk about critically appraising for anti-racism. Now, what got me to think about this was, well, it made me think that in life it's really easy to make presumptions, and it's very easy to find yourself in a bubble of seemingly like-minded people and forget that the rest of the world outside your bubble is actually rather different. My experience of academic librarianship, for instance, has been dominated by leftish-leaning, white, middle-ish class colleagues. It has got a little bit more diverse in recent years, but frankly, not a lot. And given the people I mix with at work, I kind of struggle to understand how the Tories can win a single seat in any election. And I was fully expecting a landslide vote to Remain in 2016. I'm kind of beginning to suspect that there's more to the UK and indeed the whole of humanity than white middle-ish class people. The same kind of realization needs to come to academia and to medicine. And I recall seeing back in December the surprise and delight when Chidi Ibe's anatomical pictures made the news because he'd illustrated a black person. And it's only then, when it really hits home to a numpty like me, that the anatomical pictures I'd seen until then were all of white people. And of course, that's utterly ridiculous. So we're already well aware of the wide range of factors that can lead to bias in medical research, however unwitting. The color and shape of a placebo pill can alter its effects and its efficacy. So if we don't recognize all of the factors and account for them in our calculations, in our research, then of course we run a huge risk of coming to false conclusions or making assumptions based on a narrow section of society that just doesn't apply generally. And so the work that Ramona Naicker is doing to identify racism in medical research is absolutely essential if we're to practice medicine that's for the benefit of the whole of society and the whole of the human population. So over to you, Ramona.
Thank you so much. So hi, everybody. Thank you so much for coming to see my talk. I'm just going to share my screen and hopefully it'll just work. So you should all be able to see my PowerPoint now, hopefully. Let me just minimize a few bits. Lovely. So so thank you so much for coming to see my session on teaching critically appraising for anti-racism. Can't even get the title right. So my name is Ramona and I'm an information specialist at the Northern Care Alliance in Manchester, which is for the NHS. And I've popped my Twitter handle on the screen there, so please do connect. I'm definitely hoping to have time for questions after, but this is quite a big session, so do strap yourselves in. So today, before I talk about how to incorporate critically appraising for anti-racism into teaching, I really do kind of need to go over what it actually is, because I'm very much hoping that you'll be able to incorporate into your teaching. So it's basically a little session for yourselves, and then I'll talk about how I've been using it during my critical appraisal sessions after that. I'll also be using slido.com a bit later, so grab your phones and go to slido.com and enter the code 300-400. It would be boss if somebody could just pop that into the chat as well, slido.com 300-400. I'll remind you of that later on as well, when we do actually need it, so don't worry too much if you've missed it for now. So let's get into it. So when we critically appraise, we're looking at three broad questions. So first, we're determining if a piece of research is relevant to our practice or our population of interest. Second, we're looking at the reliability of a study. So what were the results and do we believe them based on any possible threats to internal validity, so bias. And third, were the results valid? So were the methodologies robust? And so we'll see that racial bias in research impacts a study's relevancy, validity, and reliability, though presently this aspect, it's not addressed in critical appraisal tools that we use. And so consequently, consumers of research, may often not take racial bias into account when assessing a paper's quality. So there are two areas of concern that we can look out for when we're critically appraising for anti-racism. The first one is around underrepresentation. So I don't think it's a big shock to any of us that minoritized ethnic populations are underrepresented in studies. We've seen this really recently with the COVID-19 vaccine trials, and it happens all the time in all sorts of studies and trials. And then the second is around interpretation of the findings. So again, I'm sure a lot of you are aware that ethnic minorities can have different health outcomes than their white counterparts. So there's a lot of conditions and diseases that impact BAME populations more. And this also translates to clinical studies where ethnic minority populations can also have different outcomes. So the issue here is that these outcomes are not appropriately addressed, so appropriate reasons or interpretations aren't given. So why do I think that we need to talk about this during appraisal? Well, critically appraising for anti-racism doesn't only alert us to limitations in published research and gives us an idea of a study's strength and methodological robustness, but the process also underlines the importance of diversity from the beginning of the research cycle. And in doing this, it supports researchers of the future to overcome these limitations. So, you know, we who participate in, consume and appraise research, we have a role to play in its recalibration to reflect on previous practices and then actively engage to produce more inclusive research as well. So let's start by talking about underrepresentation. So clinical trial researchers, they have a duty to recruit a sample of volunteers that closely represents the population that's being studied, and that's to ensure that the results are generalizable. However, most clinicians are informed by research which has been extrapolated from largely homogeneous populations, usually white and male, and that produces then biased results, and it leaves questions about how can clinicians apply the research findings to their own patients. And, you know, if there's a lack of evidence on the impact of an intervention for a certain group, then clinicians might be reluctant to offer that intervention to individuals of that group. The government's got this vision of an NHS that puts patients and the public first, where no decision about me without me should be the norm. And so this also makes certain that all populations should be included in research. And then, of course, you know, evidence has continuously demonstrated that minoritized ethnic people are more likely to suffer and die from various conditions. So, for example, in the UK, patients from BAME backgrounds have greater risk of heart disease, stillbirths and infant mortality rates are higher among babies from Black and Pakistani groups. And then again, the COVID-19 pandemic impacted minority groups disproportionately. But unfortunately, even for conditions that disproportionately impact ethnic minority populations, they still remain underrepresented in the trials that address these conditions. So one really well-reported area is mental health disorders, where in the US, African-American patients have shown greater levels of impairment and severity of disorder with poorer treatment outcomes. And the US Department of Health and Human Services have reported that African-Americans over 18 are 40% more likely to report serious psychological distress compared to the white population. But in this systematic review on the screen here, which was looking at African-American representation in family and twin studies of mood and anxiety disorders, of the 209 studies that it included, at least 80 of them didn't include any African-Americans at all, at least because the remaining 88 studies either did not report on any data on ethnicity at all, or it reported only the ethnicity data for its white participants. So it'll have like a white and then an other category. So when the data for only one racial or ethnic group is provided, and you know, it's usually that of white participants, let's be honest, it places this group as a priority, you know, or the norm, and it further others the remaining populations. So this report and this type of reporting, it is necessary when the number of remaining or other participants is so few that publishing that racial and ethnicity data could risk breaking anonymity. And of course, that's really important that anonymity is maintained. But the restriction is just basically confirmation, it's just further confirmation that not enough non-white participants are being recruited. We can't even pop down their data in the study results. So if samples of non-whites are too few, then statistically significant results can't be produced. And you know, the results might represent random chance. So this is a key limitation. You know, these studies that could offer vast insight into the cause and effect of health disparities are then just not relevant for those who are the most impacted. So because most trials do suffer from underrepresentation of minoritized ethnic populations, when the successful interventions are being reviewed for consideration into the health system, the lack of minority representation is, of course, not a deterrent to decision making, because it can't be, because there's no choice otherwise. So we have a review here on the screen, which was looking at the disparity of race reporting and representation in clinical trials that led to cancer drug approvals in the US. And it found that despite about 13% of cancer patients in the US being Black, and 15% of cancer mortality patients being Black, Black participation in trials, which then led to FDA drug approvals, was less than 5%. And again, obviously, unsurprisingly, white populations saw appropriate representation in these trials, as they should. So this is quite literally, a Black Lives Matter issue. If Black people are disproportionately more likely to suffer and die from conditions and illnesses and coronaviruses, then why are they not represented in the trials and studies that aim to save people's lives? It's no surprise or coincidence that groups who are racially marginalized or discriminated against are more likely to suffer from certain conditions, and that they're not represented in trials either. These are all shaped and influenced by structural inequalities. So it is true that the majority of critical appraisal checklists do address the issue of representation. So, for example, the widely Critical Appraisal Skills Program, or CASP, their checklist for RCTs asks its users to consider if the results can be applied to your local population or in your context. And it prompts with different questions like, would any difference between your population and the study's participants alter the outcomes reported in the study? But these questions, they implore the user to analyze the way the results can be applied to the appraiser's local population rather than the researcher's population under study. And obviously, undoubtedly, it is the appraiser's population that the appraiser is most interested in. But this question, it doesn't allow a user to comprehensively critique a racial bias aspect of the research methodology, and it leaves little accountability really for the researchers to appropriately recruit for diversity. In their cohort study checklist, the Scottish Intercollegiate Guidelines Network, or SIGN, reminds appraisers that for valid study results, it is essential that the study participants are truly representative of the source population. So we're getting a bit closer here, and though this note does imply the inclusion of all groups who make up the population of interest, there's no explicit mention of the underserved groups who are repeatedly underrepresented. And it is entirely possible and probable that the study methodology or intervention was designed or delivered in a way that excludes minority groups who live with the condition. So this really is an essential point to explore during the critical appraisal process. So just some bits to get us started about thinking critically about underrepresentation. So some questions to remember so far. So when you're critically appraising a paper is, have minoritized ethnics been recruited onto the study? So to generate accurate interpretation of research findings, researchers must recruit for diversity. Minoritized ethnics exist in all populations, and they should be included in all relevant research. There are a lot of barriers to inclusion, which I haven't been able to get into. So it's not always possible, of course, in which case the researchers should provide an explanation in the limitations. Second thing to consider is the sample of minoritized ethnic participants representative of the population under study. So researchers also need to consider that some minority groups are disproportionately impacted by certain conditions. And if reporting on health disparities between ethnic groups, the ethnic subsamples, they need to be large enough to provide statistically significant results. And then also, is the data on race and ethnicity full and accurate? So we want to maximize data richness here. Researchers should avoid, where possible, only reporting the ethnicity of white participants and then othering everybody else. This places white populations as a priority. So now I'm going to move on to the interpretation of study findings. So once a study has been completed, how the researchers discuss and interpret the results around the differences between outcomes between different ethnic or racial groups. So I've got a quote for you, which I always bang out at these events because I think it really encapsulates the issue around interpretation. And I'm just going to read it out for you. Race is not a biological category that naturally produces these health disparities because of genetic difference. Race is a social category that has biological consequences because of the impact of social inequality on people's health. So this quote is from the author and activist Dorothy E. Roberts. And with this, what she's saying is that differences in health outcomes need to be addressed appropriately, so not put down to biology or genetics. Because for hundreds of years, scientists and psychologists driven by racism and discrimination have been trying to find biological differences between different ethnic groups or different races, whether that's Africans or Jewish people, to somehow prove that they're genetically inferior to justify the actions against them. And, do not be mistaken, like this is where the idea of race comes from. It was invented for this fact in that way. And time again, the existence of biological race, so the genetic differences between ethnic groups or quote unquote races, has been debunked. And these ideas of racial inferiority just have no place today. Race and ethnicity should be used to represent social experiences, not biological facts, to explain whatever the phenomena is under study in the paper. So as before, I've just got a few studies as examples to demonstrate this. So this one is from a now amended 2020 article in the Health Affairs Journal, which suggested that higher COVID-19 infection rates among African Americans in California might be due to unknown genetic or biological factors that increase risk severity for this population. However, there were no genetic or biological tests done within this research to warrant speculation of genetic inferiority, which is what this is. And that can be really deeply damaging to these populations who are already suffering. And because the real known inequalities were not addressed, reporting like this, it leaves its readers, to come to its own conclusions about why these health disparities occur. This paper was eventually amended, so it's been changed now, and now it concludes that the disparities in infection rates were probably down to societal drivers. So another area where race is often concluded as the cause for differences in outcome is metabolic rates, so specifically for drugs such as antidepressants. And studies have reported that antidepressants are less effective in non-white populations, are more effective for African American and Hispanic patients, that Asian patients often respond to lower doses of antidepressants, and so on. I mean, there's so many studies about this. And what's important to understand here is that any trend is linked to genetic ancestry and not to race. So a little bit of science here for you all. Genetic ancestry is the genetic origin of an individual's population, so their family. But that's different from race. It's just that people tend to, people from the same ethnic groups tend to cluster. So it might be true that race and ethnicity, it might well capture information about the likely presence of genetic variants, but ancestry is a much clearer predictor of why some mutations, genetic or metabolic conditions, are more prevalent within certain groups than others. And so you might think, okay, this is all just about semantics, but really using terms like genetic ancestry prevents researchers from resorting to notions of racial and ethnic differences between populations. But, even when concluding possible genetic differences or possible genetic factors as reasons for health inequalities in research, it is really concerning that genetic testing is basically hardly ever done anyway, especially since evidence has shown that individuals are frequently genetically more similar to members of other groups than they are to members of their own group. And, on top of that, if researchers are stratifying data by genetic ancestry, then they need to be aware that genetic admixture of populations, because we're migrating so much now, it really undermines the self-identified ethnicity in assuming genetic ancestry in that way. So I'm of mixed heritage myself, and I did a DNA test a few years ago, and the results were literally wild. I mean, I had no idea about any of that stuff, and they get updated like all the time as well. So, therefore, genetic testing really, it needs to be undertaken alongside conclusions of genetic differences based on ancestry too. So though recruiting for trial diversity should definitely be seen as essential in the planning of a research, stratifying the results data by race, might not be so essential. the purpose for including race or ethnicity as a variable should really be clarified and justified. And as appraisers of health literature, we need to consider like how race and ethnicity are relevant to the study. So how do the use of these variables improve our understanding of the study topic? And if these variables were used to support understanding of social experiences that impact the outcome. Because race and ethnicity are socially constructed, social covariates need to be reported alongside the race and ethnicity data and results. Health differences between racial and ethnic groups can really only be understood if we consider the social construct in research, so how political and historical contexts have shaped the lives of people through, access to and experience of education, housing, employment, and so on. Race should not be used as a proxy for genetic ancestry. So another reason that it's important that we notice when race is being incorrectly used as a variable, and probably the most important reason, is that research is, of course, acted upon. Its entire purpose is for us to learn and change our practice based on the evidence available. So if researchers discover disparities in outcomes between different races, but fail to give appropriate interpretations for these differences, so, racism, then that's not going to be taken into account when tools are developed to inform practice later on. Those disparities are then translated as unchangeable and unchallengeable facts because clinicians believe they're down to biology, and of course we can't change biology. So I've got a few examples of where this has happened, and the first one is an algorithm kind of tool. So this is the kidney donor risk index, and it predicts the likelihood of kidney graft failure from potential donors. And this is based in the US. So we can see in the variables section, we've got risks for failure, things like age, cause of death, things that make sense. And then we've got race, African American. So this means that this tool increases the risk of kidney graft failure from African American donors. And since African Americans are more likely to receive kidneys from African Americans, this risk reducing their chances of receiving kidney donations. African Americans are more likely to have kidney failure because of access to healthcare and prevalence of like other risk factors like high blood pressure, which racism in public health and access to healthcare will have contributed to. These factors are challengeable, but once we produce a tool like this, we almost cement the idea of biological differences. So there's loads of tools, examples like this. I just had time to show you the one, but I'll pop some more into the notes. And so then coming back to mental health, so I spoke earlier about some studies that conclude that minorities process antidepressant drugs differently from white populations. And there's a lot of evidence to suggest that minority groups are less likely to receive adequate drug treatment for depression. There was one UK study that found that Black and minority ethnic groups are up to 4 times less likely to be prescribed antidepressants compared to white British patients. And it's summed up quite well in this paper where I've got the excerpt on the screen by Cardamil. And here he found that minoritized ethnics have consistently documented lower rates of depression treatment and are less likely to receive adequate dosages when they do seek treatment. And then if we just need any more proof that this aspect of race medicine is alive and well, in 2002, New York Times Magazine published I Am a Racially Profiling Doctor by psychiatrist Sally Satel. And so here, Dr. Satel admitted to prescribing African Americans lower antidepressant dosages because she believes that Black people metabolize antidepressants slower, and she quotes research as a reason for doing that. So doctors and researchers, they are practicing race medicine when they take into account the color of the patient. So the tool that we saw just now, it wasn't created by racist clinicians, just like Dr. Satel doesn't believe she's being racist. They're aiming to provide the best care. But if the studies that this care is based on has given unsuitable explanations that biological differences between races are the cause of health disparities, then of course tools and clinicians will take that into account as well. And so this is why it's really important that we critique biological explanations for ethnic minority differences in health outcomes in research. And then this brings us to the questions to consider when we're appraising for racial bias in the interpretation of results. So remember, if racial ethnicity results data was stratified by race, was that justified? So although there's definitely a clear need for racial and ethnic representation in clinical trials, the usefulness of stratifying the results data by race or ethnicity really depends on the specific topic. Have the differences in outcome between racial and ethnic groups been appropriately interpreted and addressed? So because race is a social construct, differences in outcome can only be understood if researchers discuss the wider social determinants of health. Question genetic interpretations of race because they're not grounded in science and they promote an idea of racial inferiority. And then, did researchers avoid assigning race as a variable, a risk factor, or as a proxy for genetic ancestry? So when race is assigned as a variable or a risk factor, the idea of biological race is kind of cemented into tools and guidelines. So researchers, they need to consider co-founders, like systemic or institutional, interpersonal forms of racism that can impact outcomes as well. Race should not be used as a proxy for genetic ancestry because they are not the same thing. So what I've done is I've developed like a supplementary checklist for appraising for anti-racism. So that can be used in conjunction with any other critical appraisal tools, such like a CASP checklist or so on. It basically asks the same questions that I've just popped on those two kind of question slides, but with a bit more expansion and a few prompts as well. I'm happy to pop the link into the meeting chat after the session, but obviously the slides are being shared as well. So, so now it's time to go over how I incorporate this into teaching. And I'm really also kind of excited to hear any ideas that you guys might have as well. So really there are two ways that I might discuss critically appraising for anti-racism. So the first one is as an individual or standalone session. And then the second is kind of weaving it into generic critical appraisal sessions. So first, the standalone session. So this is, as the title suggests, a session dedicated to critically appraising for anti-racism. And the session itself isn't all that different from what you've just seen, really. And these are preferred by me because I've got time to properly discuss the concerns, provide a lot of examples of how it might look within the literature, and how it relates to theories of critical appraisal. I'll outline that for you in a few slides' time as well. The underrepresentation side of things is something most people know about. People are generally aware that it's an issue and it doesn't really require much time to explain. And it's also a lot easier to recognize within the research. You're just looking at study characteristics tables, really. But interpretation does take a lot longer because I think there's a need to go into a bit of history and science about racism and the absence of biological differences between races. The context is really very much necessary for that. And so the standalone session allows me to provide a lot more knowledge. It allows users to hopefully fully understand the topic, and also gives me the chance to introduce the tool that I've developed and go through that as well. But of course, the downsides are that it takes time. All of that takes time. And it does really require prior participant knowledge of critical appraisal, because again, there's not enough time to really go into critical appraisal theory, techniques, tools, bias, study types, and then do a whole section on critically appraising for anti-racism as well. It would just be incredibly demanding and overwhelming. So this is a supplementary session, I guess, and gaining interest for supplementary sessions in the NHS can be a little bit difficult. So then my other approach has been to incorporate aspects of critically appraising for anti-racism into my broader sessions. So most of the critical appraisal sessions I deliver are like generic or kind of whistle-stop tours, I guess, where you go over all sorts of aspects of critical appraisal during a 1.5 hour session. So we'll talk about study types, bias, and some basic statistics and so on. So in this case, I'll kind of weave in aspects of critically appraising for anti-racism rather than adding a whole kind of racial bias aspect to the session. And because racial bias does impact critical appraisal in different ways, it has worked quite well. The advantage is that I can kind of seamlessly work in racial bias into a session, like highlighting it as important to the critical appraisal process, and then hopefully kind of planting those seeds to create awareness. And it doesn't add extra time to an existing session really either. However, the downside is that I'm unable to provide as much explanation, especially around interpreting differences in outcome. It's a little bit difficult to weave into a discussion, genetic ancestry when you're delivering a generic critical appraisal session. But then that means that attendees might not always understand the true importance of correct interpretation. But I do always mention that I offer these standalone sessions for anybody that is more interested in learning more about critically appraising for anti-racism. So what kind of things might I refer to when I'm like weaving this into an existing generic session? So I always think it's best practice to give an example of a concept or a type of bias or whatever it is that you're discussing to help attendees understand. So I'll use examples of racial bias literally whenever I can get them in. And racial bias does impact a study's relevance, reliability, and validity. So when talking about relevance, we're talking about external validity. So that's the extent to which you can generalize the findings of a study to other situations, other people, settings, measures, and so on. And in this sense, I'm discussing the study's participants specifically, making the point that samples should include minoritized ethnics because they exist in all populations, and how if the samples differ systematically from the population under study by not including minoritized ethnics, then the results cannot be applied to a broader context. And of course, how this will also cause the participants to no doubt differ from our own populations if we were considering changing our practice. The results just wouldn't be relevant. Reliability and validity both increase transparency and decrease opportunities for bias to influence the research. And the purpose for establishing reliability and validity in research is essentially to ensure that the data is sound and replicable and the results are accurate. So here I can again discuss a well-known issue that ethnic minorities are underrepresented and their sample sizes are often too small. And of course, appropriate sample sizes are critical for reliable and valid results. And evidence generated from small sample sizes is especially prone to error too. Bias in interpretation impacts the reliability of results. So here I've got confounding bias as an example. So if race is being used to explain a phenomena, well, there are other factors, socioeconomic, structural racism that impact the outcome. Correlation is not necessarily causation. Race itself does not cause health disparities. There are additional variables around that. And then also maybe when discussing confirmation bias. So this is when researchers, see what they want to see in a study's results, confirm their own kind of pre-existing beliefs about biological racial differences or stereotypes, and ignore other factors as well. And then as well as sample sizes impacting validity, we might consider the presentation of the results. So researchers should always present results by research question or hypothesis. So if the results were stratified by race, well, is this even justified within the hypothesis? Are the conclusions that are drawn from this actually valid because they've been researched appropriately? And the accuracy of results can also refer to the reliability of measures used. So this is kind of what we call criterion validity. So that is the extent to which the measurement tool is able to produce accurate findings when compared to a gold standard. So here I'm referring to the lack of measurement, basically, when researchers, they often conclude on genetic differences between populations. Well, genetic testing needs to be done as the gold standard, and if not, then the validity might be impacted. So you can see that there are a number of different ways, and there are a couple more as well, that you can weave awareness of racial bias into an existing session without having to make it longer or more overwhelming. So my hope here really is that the more I mention it within a session, because in that situation, I am the expert on critical appraisal, then the participants of the session will recognize it as important to the process as well. So this slide here is a slide that I actually use during my critical appraisal sessions when I'm discussing different types of tools for different study designs. And so you can see the last tool, I've just done some very bold self-promotion, and I popped my own supplementary checklist on there as a tool for everyone to use to supplement other tools. So I briefly discuss all the tools on the screen, including my own. So again, it's just kind of more planting those seeds of getting people to recognize this needs to be addressed. For me, being online has helped a fantastic amount with interactivity. And during any quiz sections, I'll incorporate questions about racial bias with more kind of standard critical appraisal questions about randomization and p-values and all that fun stuff. And being able to use Mentimeter, Slido, and Padlet, where participants are able to answer questions anonymously, has worked really well. I think especially when it comes to race, you know, there might be some apprehension to answer questions in case they get it wrong. It's quite a sensitive thing. So yeah, being able to answer questions anonymously, I think has helped quite a lot. So now what we're going to do is we are just going to give this a go. So you guys, you know, so that you can all see how it works. And I'm going to be using Slido for this, which is very similar to Mentimeter, but incorporating into PowerPoint is available on the free version. So grab your phones if you haven't already, and open the browsers on your phone. Go to slido.com and enter the code on the screen, which is 300-400. And I am going to be reading, I'll read out the excerpt on the screen here, and then you'll be, after I've finished reading it out, then you'll be able to answer the multiple choice question about what do you think is the problem here with this study. So I'll read out the excerpt now. Black and Hispanic women had a higher incidence of breast cancer-related lymphedema development compared to Caucasian women, with Black race being the strongest predictor of development of severe breast cancer-related lymphedema. Further work should address the biologic mechanisms behind racial disparities in the risk of breast cancer-related lymphedema and possible preventative strategies. So this is a multiple choice question. I'm going to give you a few seconds. I'm just going to move on to the slides. So you should be able to see a kind of condensed version of that excerpt. So you can give that another read and then pick the multiple choice answer that you think is the most suitable. So I'm going to give you a few seconds to do that. I'm going to do it as well. Oh, hopefully it works. Oh, I can't do it in airplane mode. Fantastic. So, I mean, technically all of the answers were right, but the actual correct answer was all of the above. So those of you that are picking the other answers, technically you're still right, but all of the others are an issue as well. So yes, so here we have speculation of biological differences with no biological testing done, and with no references to other variables such as structural or institutional racism, which will impact the outcome. Lovely. So let's do another one. So this one here is a free text answer. So you can see that kind of open text feature on Slido. Again, I'm going to read out the excerpt from this 2019 study. Among self-identifying African Americans, a statistically significant negative correlation was found between interviewer-rated darker facial color and vocabulary scores. So this is a free text one. So just write down what is wrong with that. I mean, there's quite a lot wrong with it, really, isn't there? Everything. Yeah. Just absolute sheer. I mean, it is just unbelievable. Can you believe that this is from 2019? So interviewer rated, I'm glad someone said that. Yes, fantastic. So first of all, correlation is not causation. You know, skin color does not correlate to vocabulary scores. Absolutely ridiculous. You know, there are lots of other, if that was true, you know, there's just so many other variables that need to be taken into account to determine someone's vocabulary scores. Unbelievable. And yet also interviewer rated. Well, you know, let's be honest, this interviewer was probably massively racist, probably had quite ingrained ideas about skin color and intelligence, which are ridiculous. So I'd certainly hazard a guess there's a bit of confirmation bias coming into this. So yeah, so thank you for participating in that. So that was just to show you really how interactivity might work throughout a critical appraisal session. And I definitely recommend Slido, just because I can pop it into my actual PowerPoint without having to kind of faff about with changing screens and stuff. But yeah, fantastic. So thank you so much. Let's see if I can move on to this. Lovely. So something that I haven't had a chance to do yet, but I'm currently in the kind of planning stages of, is incorporating this topic into one of the journal club sessions that I'll be supporting soon. So usually when I start supporting a journal club, I'll basically I'll pick the paper and I'll be the presenter for a couple of sessions while the rest of the group, kind of find their feet and get a bit more confident about it. So what I'll do, my approach is to pick a paper that I feel has a certain issue or aspect of strength maybe, and then I'll discuss that or teach about that going into the session as a, as a kind of theme for the session, I guess. So it might be a type of bias that's prominent or a study type that stands out to give it a sort of theme. So I'm planning on doing this with a paper that I'll have identified racial bias in, or a paper that's handled race and ethnicity reporting really well even. So then I can give a mini session on critically appraising for anti-racism, share my supplementary tool that I've developed that we can also use in the session itself with any other study-based tool as well. So as I said, I haven't actually had the chance to do this yet. It's coming up, but I did just want to share that with you in case any of the rest of you get to give it a go. So do please let me know. And then, of course, there's kind of like the marketing around these offerings. So how I'm making people aware that these sessions exist and my work around it as well. So what I've got here is just a screenshot of the critical appraisal training section on our website. So what users can expect from a session really is briefly mentioned. And so here you can see the highlighted text and it's advertising a session on critically appraising for anti-racism. So the approach that I've taken here is just to offer it like any other session, that when people make a training request on our online request form, they can tick it as an option that they want to have training on it, because it does really work best as a separate session. And then following on from that, this is the kind of part of our website where we link to critical appraisal resources and tools for our users. And again, I've been quite bold and popped mine on there at the bottom. So there's a tool as well as a link to a presentation that I gave, which kind of goes over what I did during the first half of this session, so that users can watch that and learn more and make use of the tool in their own time if they'd like to do that. So when people seek critical appraisal assistance, we'll usually direct them to this part of our website. So hopefully kind of, again, raising that awareness that this is an important issue. So what worked best for me personally was to present it to our BAME staff network first. So I am a member of the network, but anybody can approach their BAME staff networks or EDI networks to offer sessions during one of their meetings. And from my experience, they're always looking for speakers and opportunities to develop their skills and their networks. So of course, the BAME staff network do have quite a it's close to their hearts. They themselves are mixed professions. The majority of our BAME staff network are clinical, so they've got some experience with critical appraisal already. And then there is also leadership and management representation within the network, so that kind of that awareness of the session gets passed on to other staff groups within the trust. I recently heard that a librarian at University Hospitals of Derby and Burton will be presenting this to their BAME staff network, so it's really good to see others getting it out there. So I do encourage you to do the same. And then the next staff group I've approached is the R&D team, who I'm going to be presenting it to next month. And really, I just mention this any chance I get. So at inductions, during other training sessions, meetings, social media, like whenever I get the chance. On the screen is an example of this. So this is a tweet that I replied to using our library account. So I always try and engage with users over Twitter. And so here a staff member in our trust tweeted about equality in the NHS and Salford in particular, which is where I work. So I just jumped on that basically to make people aware that the library service are doing what we can to promote anti-racism in research, including through this critical appraisal session. So it allows us to be seen as an ally as well. And then because of our connections with the BAME staff network and our relationship with the research department as well, it allows us to reach a number of people. So we always get involved in BAME staff network initiatives, Black History Month, Asian South Heritage Month, and these are always really great forums to discuss this work. And this is where our good relationships come in really. Our research department, we're very close to them, we have a great relationship with them. They retweet almost everything that we tweet. So they retweeted this about us having a session on critically appraising for anti-racism to just kind of garner some interest for us as well. So like anything in library outreach, you just find those opportunities and just promote as much as you can. But The project hasn't really been without its challenges, of course, and there are still loads more to overcome. First of all, it's a work in progress, and that means that I'll do some research and then have more of a focus on an issue, and then need to amend my supplementary checklist. I'm constantly changing it all the time. So the ideas that I've got on the research is not finished. So my sessions will keep developing. This session that I delivered Tuesday is vastly different to the first one that I ever delivered. I've made mistakes, I've had to change them. So I'll be glad when I'm in a place where I feel comfortable with it. And that leads me nicely to my next point. So as you've seen, I've had to do quite a bit of looking into the science of like race and genetic ancestry, and being able to understand that and explain it correctly has been challenging. I'm not a scientist or a clinician, so that's been difficult. But I personally have been incredibly lucky that I'm part of a systematic review team, which is looking at inherited diseases. So the consultants on that team have been really helpful and supportive, and like developing my confidence around the topic. And it really also just goes to show that, you know, the importance of connections within your role, within your trust, place of work or whatever. That being said, at the moment, the other librarians in my team haven't had the chance to feel fully confident with it yet. So it's largely myself that delivers the standalone session for the time being. And it's because it is such a sensitive issue, and people are very afraid of getting it wrong. But, you know, as I've said, I've gotten it wrong so many times myself already. And I think with progress, we have to accept that we're not always going to get it right. We're going to slip up. But, you know, these are just the things that we have to get to, and hopefully in my team the other librarians will feel confident, will feel like they're in a place where they're confident enough to deliver it. So next, as I mentioned earlier, of course, time. Nobody has enough of it, least of all busy clinicians or students that are just trying to get their work done. I think with students, especially when they seek out critical appraisal training for a specific purpose, you know, they're doing like a dissertation or something, and they might not really be interested in adding more to a session if it's not really necessary in that way. But that's why I continue to weave it into requested sessions and promoting it as much as I can. And I really hope that during journal clubs is when this, you know, because it's more kind of discussion based and a little bit informal, is when this kind of really gets to shine as well. And then finally, reaching the wider community. So outside my trust, I've had the chance to speak at various events now, including the NIHR, which has been brilliant. And I did start planning a supplementary checklist with CASP, the big dogs themselves. They were really interested in taking this further, but unfortunately that has just come to a complete stop due to funding and other coronavirus related issues. And I'm really not sure it's going to be picked up again. CASP would have been fantastic because it really would have like cemented the idea that this is important. But, you know, until that happens again, then I'm pretty much relying on the wider community, so you guys, to help me spread the word and include it in your sessions. So please do make use of my tool. Come and invite me to speak if you're not feeling confident enough yourselves, or obviously just get in touch if there's anything else that I can do. But let's end on a positive. So the feedback that I've had from presenting the sessions has been overwhelmingly positive, and they really highlighted that the issues that are raised are really important to people, and it's something that they'll be thinking about going forward for sure. And I think, you know, we as a community, we talk a lot about being allies, and this really is the chance to demonstrate it in the work that we do, the stuff that we teach, the work that we're experts in. And the nice thing about it is that if you already teach critical appraisal, then you are already set up to include it as well. So thank you so much for listening. I'll be really happy to take any questions if we've got time. Otherwise, do contact me as well afterwards. I'm absolutely made up every time someone reaches out to me about this, so don't hesitate. Thank you so much. I'm going to stop sharing my screen now, if I can.
Fantastic. Thank you so much, Ramona.
Thank you.
That was a fascinating, but I think really powerful and important session. So thank you so much for that. And I'm just kind of so sad that collaboration with CASP has stopped, because that I think would be incredibly important to get it embedded as part of the official tool, to really get it on everyone's agenda.
And they are interested. They've had a few issues because of coronavirus themselves. which I don't think I'm allowed to say, so I won't. But the work that they were doing was they were doing it for free, basically, if they were going to develop this. So, you know, obviously they have to do paid work before they do free work. So it is completely understandable. But I do hope that that it does get picked up again.
Yeah. Thank you. I'm going to mix my metaphors, so I apologize. Like a real massive clash here, but I do feel, you know, I feel like you're the doctor. I'm coming up to the TARDIS here, and I've come into it thinking, right, this is going to be a big problem. It's going to be like house sized, and you've opened the door, and I've walked into Wembley Stadium. But it is kind of mind blowing. But I mean, incredibly important. There's so much there. I'm going to hand over to Ida in just a second for some questions, but I did get one sent to me directly. So Zoe's asked, do you think that we inherently end up with a bias from the start when we look at only English language material?
Well, of course, definitely. I attended a conference years ago, and it was about a researcher, and he was in Africa, and he was saying how all of his, you know, they produce fantastic research there, but they basically have to publish it in English. A lot of people then choose not to publish because, you know, obviously it's a huge language barrier, so English or French that they could choose to. So there must, you know, the amount of research that's out there, which has been done by all these fantastic researchers that we don't have access to because we're not, you know, because of the language difference. Yeah, absolutely. I think we are set up with that inherent bias. I would absolutely agree. Yeah,
I'm sure you're right. Isla, do you want to just run through some of the questions that we've had in the chat?
I'm a little nervous, Ramona. You have set yourself up to be asked by a lot of people because a lot of people are hugely impressed. Just running through the questions that have come through. Thank you so much for this amazing session. One comment about minoritized ethnic being a piece of terminology that was new and that was different to the BAME and a variety of others I'm sure that people might normally use. So an introduction to a new piece of terminology. It's also important, another question comes, it's also important to think about how we're recruited in the first place. Is one way of doing this going to elicit the best pool of people? So it's, think about recruitment.
Yeah, I think there's so many issues around recruitment. I didn't really get the chance to go into it, and of course I'm not an expert on like study recruitment processes either, but you know, everything from like culture and language, location. I think a lot of the places where big studies are recruited, you know, it's the inaccessible for minority populations, the language that's used. I also read a piece recently that was about because researchers are under so much pressure to get stuff out so fast that it's just easier to recruit, you know, in their kind of set up places, which will be in areas where it's mostly white and whatever, just so that, because they've got so many constraints themselves and under so many pressures. So it comes from all sides, really. And then of course there's a lot of like racism, whether it's contemporary or historical racism, that people, you know, make people apprehensive about, you know, going into trials. And there's so many issues around recruitment. It's such a multifaceted thing. It's going to take a lot of work to sort out, definitely. Yeah.
A question from Lucy. We've had issues in critical appraisal courses with researchers coming along not wanting to discuss other things but wanting very specifically to talk about their own research, which sometimes is great for this, but other times it would be less so. Is this something you've encountered in your own session? How do you manage it?
I haven't encountered that actually, but I guess of course, you know, they are going to be interested in their own research, but there's no reason that we can't apply, you know, the tools that we're using to another person's research. And in fact, that's probably best. You know, these are the people that we want to reach. In fact, you know, they are literally doing research. So if we can get them and be like, have you even thought about all of this? Then I would, definitely encourage that. I actually really hope that I do get a researcher that asks me to critically appraise his own piece. That would be fantastic.
Yeah, suddenly realised, oh crap, how did this get published?
Yeah.
Which raised a couple of comments about how does this stuff get through peer review, and we sort of in the chat it was a case of most peers are going to be white men, so they're not going to see where the problems are, so it's just going to be oblivious to it all. And
that's it, isn't it? Like, you need to recruit for diversity and to see these things, you need to have diverse teams in the first place, because you don't, you know, as Rick said earlier, you just kind of don't know until you're faced with it and you're like, oh right. And of course, you know, diverse teams will recognize these issues a lot more. Yeah,
which I'm going to take a liberty. Do you get self-selecting attendees attending the sessions on anti-racism critical appraisal? Is it would there be a stealth approach in relation to incorporating all of the same elements, but in a standard critical appraisal session?
So, I'm sorry. So, do you mean like if?
It's because if people aren't interested or don't think that it's a real problem, they're not going to feel attracted to a session talking about anti-racism.
Right, yeah, exactly.
Appraisal.
Absolutely. So I think like as I mentioned earlier, that is the standalone session would be preferred, but gaining interest for that is not easy. And the only people that have approached me to actually deliver that have come from when I've presented it to the BAME staff network. So that's kind of garnered interest. But outside of that, although I advertise it on the website, people don't really tick it. So that's why I think it is important to incorporate into the generic session. So you kind of plant those seeds and see like, this is an issue that you should be thinking about, and still, tell people about the other session. But yeah, definitely it's a lot harder to garner interest for a standalone session because it's not kind of deemed necessary in that way. So hopefully one day it will, things are moving all the time. So hopefully one day people get more interested in that.
And that's why having it incorporated into CASP would obviously have been beautiful.
Absolutely, yeah.
Such as life. Few other just comments, all hugely positive. Keith says that he's going to take your list to the medical student EDI group and to the leaders into the MSc in health research. I've got a global health topic that I'm really interested in.
Oh, brilliant! Oh, thank you.
Yeah, he also raises the point English language is the issue, but accessing databases from Global South, because standard databases are not good at indexing material from outside of the West/North. It's just a nightmare, isn't it?
It is, and there's so much, isn't there? Like the more you get into it, the more you realize that like there's so many barriers to us being like truly inclusive. I know it's mad.
Really, it's just fantastic. Gillian wonders, do you consider or highlight the author expertise and background in terms of how that affects their management and interpretation of the research?
Well, it's not something I have done, but it's definitely an interesting angle. I think, the examples that I used were pretty, that one really super extreme one was from a journal that is known for its like pretty racist views, but it's just to highlight kind of what the issues are. But no, I think so in that case, the author, if we were talking about that author, he is just a mad racist. I think you can look him up on Wikipedia. It's mental. But I think definitely incorporating the author's like views, their affiliations, even all the things that they've been involved in would be a really interesting angle to see how they've interpreted what they have. Yeah, definitely.
Yeah, fantastic. We're going to have to wrap up. You've provoked so much thought. There's been so much chat. I hope you have a chance to go back over the chat and take a look at some of the wow, you're amazing, but also some of the questions and comments that have come through. Thank you.
Thank you so much. Thank you so much for everyone, and thanks for all the nice messages. Thank you.
There's great interest in a train the trainer session. So
fantastic.
Prepare yourself for the potential for that. Thank you so much, Ramona.
Thank you.
I'll pass back to Rick.
Right, thank you, Isla, and thank you, Ramona. That was absolutely amazing. Right, so summing up, really, that has been, I hope you'll agree, a really interesting and useful conference. Personally, I found it absolutely fascinating, and I want to say a huge thank you to all of our speakers. And it's great to see so much good work going on out there in our profession.